Welcome to our Serious Adverse Events and Engaging Your Governance Board webinar today. It's our 124th webinar, and we're so pleased to have a wonderful speaker today, and my name is Charles Denham. I am going to be the Master of Ceremonies today, and I'm really, really honored to have a great group of speakers today. My job right now is to just undertake a couple of the housekeeping details. Please make sure your WebEx volume is at the maximum, your computer volume is at the maximum, and your external speaker is on the maximum. And I'm on slide 3, just for those of you that already have slides. Slide 4 shows you how to request a phone line if you are not experiencing good audio. Please go ahead and go to the participants window and click on the phone icon, and you can request a better phone line because we want to make sure that you get good audio. On slide 5 is, for those that do have the slides, where you will be able to come back to download additional resources regarding the topic. For those of you that have called in or don't have the slides, please go to www.safetyleaders.org, go to the upcoming events in the upper right-hand quadrant of the landing page, and click on today's webinar. That will take you to a page where you'll see Tom Vanderwark, our wonderful speaker today, and this is where you'll be able to download additional resources in the future. For those that are watching on demand, we will continue to add resources to this page regarding this topic as well. On slide 7 are our social media addresses. We keep a pretty minimalist approach in social media, but we do have addresses there. On slide 8 is our purpose statement we take very seriously. Our purpose is we will measure our success by how we protect and enrich the lives of families, patients, and caregivers, both. And this topic today really addresses that. Our mission is to accelerate performance solutions that save lives, save money, and create value in the communities we serve and ventures we undertake. And our disclosure statement is on page 9. And other than Tom Vanderwark being a consultant in the field of governance, no products, services, pharmaceuticals, or technology products will be discussed in any way, and none of us have relationships with those. Our speakers and reactors today are Tom Vanderwark, a real leader in governance, leadership and best practices, Arlene Salamandra, who has been a tireless safety champion and consumer champion, who's one of the team that actually helped push the hacks over the goal line with CMS, which became clear in December this year when the former CMS leader was able to let us know that that was the case. John Nance, who is both an attorney, a best-selling author, but also a governance leader as well, and he will be reacting to Tom and underscoring Tom's message today. Arlene Salamandra is a former board member and staff coordinator for Families Advocating Injury Reduction. She is one of our patient advocates that has met for now more than a decade every other Saturday morning to focus on patient safety and quality issues. She was a co-author of the patient and family section of the NQF Safe Practices for Better Healthcare, and again was one of the team that was involved in a grassroots approach to provide the evidence to CMS to get the hospital-acquired conditions over the goal line, which have now saved more than 8,000 lives and $2.9 billion as of 2017. Arlene, it's great to have you open for us, and you'll close for us and be one of our reactors. Arlene, can you help us focus our compass heading today?
Okay, thank you, Dr. Denham. First of all, I'd like to welcome everyone to our webinar today. I'm really looking forward to the presenter and learning more about the importance of engaging our hospital board when addressing adverse events. But I think as a patient, I can't stress enough how important it is to keep in mind to engage the patients and their families in the process of root cause analysis. I think that's a very important part that we feel a little left out of. So thank you, everyone, for being here, and I'm looking forward to what I can learn. Thank you.
Thank you so much, Arlene. We really appreciate it, and we appreciate your tireless contribution to focus also on bullying in healthcare. You've been a wonderful champion of that area. So my job now is really to address what's in the news. I am going to very rapidly go through a number of slides so that we give a generous portion of our time to Tom, and then we can look back on some of the topics. Our first in the news, however, is that one of our favorite and most wonderful leaders in patient safety and quality is Tom Nolan. Tom was a terrific contributor to healthcare with enormous contributions to performance improvement, and the Institute for Healthcare Improvement passed away last night. He was the co-author of the Improvement Guide, which so many of us read and reread during our safety and quality journey, and he was a contributor to many, many publications and many initiatives and presentations. Noteworthy are a few: the Triple Aim, which Don Berwick then took to CMS, that was co-authored with Don and John Whittington, another fabulous champion. He wrote The Balance Between Quality and Cost with Maureen Bisignano, and the All or None measurement that raises the bar in performance in JAMA. And we've given you those links to remind you. And our thoughts and prayers go to his family, and we want to remember him for his tremendous contribution. That said, we are going to just provide a quick update to the MedTech program, which we've been leading over the last 3 years with leaders from MD Anderson, Stanford, UCSF, and a number of programs in bystander care. 2 articles have just been published in the November, December, and January and February issues of Campus Safety. The next article that will be coming out is applying the leadership approach to rapid response teams in our hospitals, in churches, and in universities. The first article was bystander care and the focus on 8 life-saving areas. The second article that you see on slide 16, and both will be available to be downloaded from the webinar page, is the uniqueness of active shooter events in hospitals. And we review a New England Journal of Medicine article and add to it, and there also is a YouTube video that we've provided to address this. And it's terrible that in the news the issue of the death toll rising to 50 in the New Zealand mosque shootings. Again, the estimates are anywhere between 10 and 40% of the people that are involved in mass casualty events. Had they had Stop the Bleed kits and known the Stop the Bleed principles, many people can be saved with extremity wounds, and from what we've learned in Iraq and Afghanistan. And Dr. Berwick, by the way, was the chair of the Institute of Medicine, or now the National Academy of Medicine report that came out on trauma care. Terrible to see this, but it's so important that organizations prepare with Stop the Bleed. And in fact, tonight we're working with a local scout group to put Stop the Bleed kits together for a school of 1,200 kids and a church that's on site there. So this is definitely a community effort. Second is this continuous issue of sudden cardiac arrest, another story that you can use in your messages as you try to get bystander care programs going, of a fireman that was saved by the very defibrillator that he had just installed. Opioid overdose is one of the 8 target areas of MedTech. And just the next slide is just a quick update on another antidote that has been fast-tracked by the FDA. We're still in MedTech recommending Narcan, which can be obtained at low cost, and many of our organizations are getting standing orders to do so. Captain Sully Sullenberger was one of the speakers in our Discovery film, has just been quoted regarding this issue of the strong business case for quality and safety. And Tom Vanderwark, who will be speaking today, has been able to apply these wonderful principles in the maritime industry as a CEO and cross over to his great leadership at Virginia Mason. So has Sully done this in healthcare. And as we follow the Boeing 737 MAX 8 issues, those of us that are aviators and know a lot of the inside story are finding that so much of this is actually education. And the parallel was an article that came out this morning or yesterday. It was available this morning, but came out yesterday, was regarding the 727. And in a similar way, the pilots had not been adequately trained regarding how quickly it would lose altitude with deceleration. So there were 4 crashes of the 727. At first they thought it was the technology, and then they found that it was, again, pilot education. So education is such a vital element to that. Another article just came out regarding EHR. Go ahead and dig into it. It's a report on study of EHR and why this is such a critical area for us to focus on, which we'll be coming back to this year with another webinar on that area. Again, I'm moving very quickly to give time to Tom, and 10 minutes after the hour, and just we'll be done very quickly on In the News. The stories we're following for you and for us that are being developed into case studies in patient safety are the Johns Hopkins crisis. There are now more than 24 articles that have been written, investigative reporting by Tampa Bay Times, and then supplemented, and it's being picked up by the other press, the Baltimore Sun, of all 6 of the facilities at Johns Hopkins. The issues regarding cover-up, retaliation against caregivers, cardiac deaths, and a number of issues. The second is the Memorial Sloan Kettering conflict of interest issue. And Tom, we know this is just a critical board issue, although board oversight's absolutely one of the questions people have about Hopkins. But at Memorial Sloan Kettering, the conflicts of interest of non-declared financial relationships, and resulting in a number of loss of positions of leaders with undeclared financial relationships, and the board of directors investing in a startup. The Baylor St. Luke's Medical Center issue regarding their cardiac program, and again, investigative journalists pull back the curtain with ProPublica and Houston Chronicle regarding their cardiac program. The Brigham and Women's 31 retractions of frank medical fraud, and this just hurts our hearts to know so many of us have worked so closely with the Brigham, and to have 31 articles retracted, patients receiving stem cell treatment for cardiac disease, and what is reported to be outright fraud and in their research. And then the most recent case, which all of us are watching very closely, about the nurse at Vanderbilt who was involved in a death. And we're following these to learn from these. Just reminding you of the letter from the NIH regarding the failure of financial disclosure, and what's prompting an awful lot of the curtain being pulled back. So this is critical that safety and quality leaders have 100% transparency of their financial relationships. The forms that are provided by journals and meeting organizers aren't enough. I've personally learned that. I think it's really important that we're just fully transparent. The Tampa Bay Times articles are just continuing to roll out every week. There's an article on February 27th regarding how the story was developed of the Hopkins crisis, and I think the lesson there is that it's so critical that we really have just solid documentation of what we're doing in quality and safety. So in order to give Tom all of the time I want to give him, there's more detail on all of the articles in the resources section, and will be posted, so I don't belabor the point. The Memorial Sloan Kettering story, though, recently they have increased their focus on conflict of interest and relationship of their senior leaders with industry. And the chief medical officer, where this all started, has just left the organization and did go to pharma. So this is in the news and will continue to be. So enough on in the news. We'll all hold Tom Nolan's family in our thoughts and prayers. This is a quick recap of our webinar from last month, From Burnout to Esprit de Corps, by Dr. Stephen Swenson, our longtime collaborator at the Mayo Clinic, and the articles that were summarized, including the AMA physician burnout articles, in Medscape, the articles that Dr. Swenson has published, and the AMA are all addressing this critical issue. And you'll find that we ask you, would you like to have more presentations regarding organizations who are focused on physician, caregiver, nurse, and administrative burnout? And 53% of you last month gave us a 10. So we are going to invite an organization or organizations to give a webinar later this year on how they tackled burnout the way that they did at the Mayo Clinic. Are there other ways to do it? On slide 35, I won't go into the detail, but you provided ample information that you would like to have be addressed in that webinar. And so you could review that on slide 35. We asked the question regarding, are you interested in a webinar presenting working with governance boards after serious adverse events? And this was to help Tom see the interest of you all. And 30% of you gave it a 10, 70% agreed, a little bit more of a distribution. And we'll be polling you again today to ask regarding whether you'd like to have additional board governance content. And on slide 37, a little bit more detail there. We asked you if you wanted more on mortality reviews. We've covered this topic very frequently, and we're still seeing 26% of you have given it a 10. In May, we'll have a thorough update from Dr. Huddleston from the Mayo Clinic on mortality reviews and what the latest information is on that topic. And again, slide 39, you've given us the detail that you would like to have there. And then finally, we're continuing to see, as with the nurse at Vanderbilt, how critical it is that we rally around our caregivers in this environment where the media can actually, in the court of public opinion, there's already a court of public opinion. The jury of the population starts to gain momentum even before we know the details. The nurse at Vanderbilt is one of the cases we're following, and the nurses have really been rallying around her. This is one, Tom, that we want to address. What do we do regarding the caregivers that are involved in these accidents? The latest information on February 25th was that health officials found no reason to discipline her after the deadly error, and we're waiting to see more of the information unfold. It'll be a really good case study for us. So at 17 minutes after the hour, I'm wrapping up now in my introduction to Tom Dawark. He was a contributor to the Framework for Effective Board Governance of Health, the Health System Quality, and chaired by Beth Daly-Ullum, and a number of contributors that we all know. This white paper will be posted on the page, and you can see the authors of this research summary, as well as the recommendations. Then there are two documents, and then a third, which is an online assessment tool. And I know that Tom was a contributor to this overall program, and perhaps you can give us a little bit more in our dialogue, Tom, regarding these valuable resources. So that brings us to Tom Dawark, and we're on time here at 17 minutes after the hour. I've known Tom for years. Tom was just a steadfast and enormous supporter of board governance best practice. I've spent many hours with him and learned from him. He is a brilliant guy who has done a terrific job at Virginia Mason Board, and he'll share more of his story there as both a board member, also as the chairman of the board. Many don't know, though, that Tom was a very accomplished CEO with a lot of experience applying high reliability methodologies in the maritime industry in multiple capacities. He I know, tongue-in-cheek, says he fails retirement and has done turnarounds, which is really an important and a very challenging thing. It's one thing to run a great company. It's another to use some of the principles he'll share with you in turning companies around. And values-driven, absolutely terrific. And I think his work with Gary Kaplan and their board was absolutely contributive to them being named in the top 100 hospitals. I first met Tom, if you remember, Tom, when you represented Virginia Mason and won the award with the Leapfrog Group back when we chaired the Safe Practices program. And so we were very honored to have you speak with us today. And Tom, take it away from there, and then we'll have reactions from John Nance and a discussion.
Great. Well, thank you, Chuck, and thank you for all that you do in hosting these on behalf of patient safety. And a great many of thanks to all of you that are attending today. I have a great appreciation for those at the bedside. You do great work 24/7, and sometimes not appreciated as much as you should. And I would like to recognize how much you do and how much that's greatly appreciated by all. A quick story that I always like to share at the beginning of a conversation. And this deals with what's a tugboat have to do with healthcare serious adverse events. So I had the honor and the privilege, actually, of serving as CEO for Foss Maritime for over 20 years, operating 150 tugs, 100 barges throughout the U.S., including Alaska waters. Shortly after I became CEO, one of those dreaded calls at 2 a.m. Rang on the home phone. And I was advised that we had lost a sailor overboard in Alaskan waters. The crew was not able to pull him on board, and he subsequently drowned. Tragic day for all. He had the right gear. He had a survival suit on. He was doing the right thing in terms of reconnecting the barge to the tug. What we did not have, as we learned, was appropriate gear to get him back over the bulwark of the tug and onto the deck. And his crew that he'd worked with for a number of years spent an hour trying to get him back on board and subsequently had to retrieve his body from the water. I had the opportunity, if you will, the obligation to meet with John's family, his mother, his father, his grandparents, his wife. And it's one of those moments that you never, ever want to have to go through again, but you know it's the right thing to do. They wanted to know what our patients want to know when an adverse event happens, particularly a death, and that is, what happened, how did it happen, and what are we doing to ensure it never happens again? Subsequent to the meeting with the patient's family, 5 days later when the tug returned to Seattle, I met with the tug crew in their work environment, and it was the same conversation. What do we do to ensure that this never happens again? This event took place some 20 years ago. We didn't have policies and procedures other than safety for dealing with this sort of event, but we used common sense. And we used empathy, we used apology, and in the healthcare terms, we disclosed, we apologized, we used just culture, although we didn't call it that. This was not an event that was caused by the crew or anybody aboard the vessel. It was an operational responsibility that we had as a company to provide the right safety gear. And we brought the board immediately into the discussion. 10 days later, we had data aboard all 100 tugs to ensure that the incident never occurred again. The board supported us in that regard. Everybody was on board for that event. And the point I am making here is twofold. One, perhaps a better understanding of my passion for safety and quality and the response to adverse events. And number two, sometimes we get so tied up in what policies we have for responding to an adverse event versus what's the right thing to do. And how do we address both the patient that's involved, the staff that's involved, and ensuring that the action never occurs again. So a lesson from high reliability industries that stuck with me for some time and hopefully is an example in terms of what we should be doing in healthcare. So our learning objectives today are to, first of all, recognize the impact a board can make when it's effectively engaged in a serious adverse event. The ability to understand how stakeholders, all of you, can work with the board to enhance the focus on serious events. Action. What actions do we take? How do we learn about and apply the leading practices for a board and stakeholders working together to reduce patient and staff harm? Board cannot do it alone. And so when I'm talking about leading practices, we're talking about collaborative practices that a board and the stakeholders in support of the board are doing to reduce patient harm. And frankly, the inspiration that at the end of our discussion, you'll be inspired to do a minimum of 3 things that you, regardless of your role in the organization, can promote board engagement as a stakeholder in reducing patient harm. So we're going to break our discussion into 3 components: raising the awareness in terms of the importance of adverse events, enhancing the focus, and the preventative piece committing to zero harm. So when I chat about leading practices, I'm not using the term best practices so that we're not confused with the long research that takes place in clinical studies to get to best practices. But I'm talking about those practices that have proven to make a difference by many, most recently in the IHI white paper that Chuck mentioned. And they're being offered for consideration, not for this is what needs to be done. And again, they're leading practices not just for the board to take, but board and those who are collaborating with the board to address the serious adverse event discussions. In terms of a serious adverse event, many descriptions out there that we can look to. My point is that you need to be the one who defines serious adverse event for your organization. It certainly needs to be all preventable deaths to patients, staff, or permanent harm. In my view, it needs to be all near misses that would result or could have resulted in death or harm. And it should also include those reportable events from a state perspective or a CMS perspective that you are required to make. That's how we can get in front of the board the types of events that we have and the importance of addressing them. The first issue that I would like to cover is the need for board engagement. So lots of people like to take a look at what we do in healthcare from a financial perspective, fortunately or unfortunately. From a board's perspective, the buck stops at the board. The board has to provide the bucks. And the board investments in safety and quality improvement have been shown to not only move safety and quality performance forward, but also the performance organization-wide, because those actions that we take to improve safety and quality also improve other performance indicators within the organization, including financials. The board is ultimately accountable. It wasn't too long ago that adverse events were thought to be clinical issues only. No longer. The board is responsible because it represents the community's best interest as a responsibility. It provides vision, mission, and culture direction, approves strategies, sets broad goals, and selects, evaluates, and supports, and holds the CEO responsible. It therefore has the power to make a difference. Committees play a really important role and frankly do most of the work of the board in terms of safety and quality improvement. And it's not just the Safety and Quality Committee, it's credentialing, compliance, finance. For all of you that are not necessarily in the boardroom, but may be influencing the board committees, it's a great approach in terms of getting adverse events, best practices, leading practices in front of the board and trustees. Also, we need to remember that every trustee can make a difference and should be engaged in making the safety and quality decisions that will improve care. Lastly, governance does matter. A number of studies have shown, research has shown, we have a building body of evidence, including in the IHI framework, that when a board engages in safety and quality, things happen, performance improves, and reductions in harm take place. So get your board engaged with some of the practices we've talked about. The next event can happen at any time, and consequences, as we know, can be significant. So it's a collaborative approach. Nothing can happen in an empty boardroom, if you will. We have to make sure that the board is supported in terms of what they do. And I know that not all of you, and probably few of you, are actually board members. Some may get into the boardroom, more may contribute to committees, but all of you can contribute to engaging, supporting, collaborating with the board in terms of making an overall difference. And we'll talk about those practices. Mary McLean died at Virginia Mason in November of 2004. It was certainly the darkest day in the organization's history, but also led to the most enlightening period. Mary was a community leader, a mother of 6, long-term patient at Virginia Mason. She came to the hospital for a routine procedure, mistakenly was injected with chloroxidine, antiseptic, and the confusion occurred because there were 3 identical containers on the procedural tray, contrast dye, saline solution, chloroxidine. And she was injected with the antiseptic and died 12 days later. Changed the course of history of Virginia Mason forever. One of those calls from the CEO that you never, ever want to experience. But it was an enlightening period. We recognize that, quote, it can happen in our organization, and it did. We assumed organizational responsibility, and this is back in 2004 when, frankly, there was not a lot of self-admittance in terms of incidents like this that was going on within our country, within our region. But it was the right thing to do. We looked at family first, organization next, and community responsibilities close behind. We were run through the ringer by the media for a number of days, but subsequently everyone understood that we were going public for the power of ensuring that it never happened again, and all organizations could learn from the incident. We used open disclosure, although we didn't call it that at the time, in terms of apologizing, meeting with the family, telling them what happened, why it happened, and what we were going to do to ensure it didn't happen again. We protected the caregiver. The physician who actually injected the antiseptic happened to be my caregiver and was devastated. And we needed to protect him and support him for a number of months after the event. It was the organization that put him at risk for this. It was not his fault. And therefore, the organization needed to take the steps to ensure it never happened again. The board was immediately engaged, and I'm going to talk in a few minutes about raising awareness, the commitment to zero, the focus on culture, and honoring Mary and his family and her family on the improvement journey that we took to ensure never again, and ultimately to become the quality leader in healthcare and being recognized as a top 100 hospital. So raising awareness. We can't have people turn to adverse events and the importance of adverse events unless we make them aware of the importance. It'll just become another flavor of the month. So what we need to do is prepare a message organization-wide for the board, yes, but organization-wide that talks about the frequency of adverse events, the performance trends that we've had over time, gaps to local and regional competitors, and really important, gaps to best performances and who is performing at zero harm. We need to describe the types of harm, not just narratively describing, but graphic pictures of harm outcomes. I will always remember the time in our Safety and Quality Committee when we were talking about pressure ulcers. And we talked about them, and then we saw a picture of a stage 3 or stage 4 pressure ulcer. And we got it. We understood the need that the board had to support work on reducing harm as a result of pressure ulcers. Plenty of other opportunities out there for graphic pictures, as we all know, but we need to make the data data visible. And number 3, we need to make the data personal. We need a patient to share their story of harm. We need a family to share their story, and stakeholders to talk about the effects of harm from an employment standpoint. Make the data personable so that everybody understands that this is an issue of moral responsibilities from the heart in addition to our legal responsibilities. We need to make the economic case with respect to reducing the effects of adverse events. There are a number of resources out there in terms of national costs. Pressure ulcer, for example, which is the most common adverse event, cost per medical error is in the neighborhood of $9,000. Central line infections, most recent data, $83,000. But the economic case needs to be within the organization. Has to be your cost. Has to be made by the CFO and your financial staff. Not only the cost, but what's the revenue loss? What's the revenue volume exposure? We know patients are shopping for quality and safe care. What are the compliance risks? And ultimately, with a situation of rental harm that results in death, what are the reputation concerns that the organization has? Then we need to make the financial case for investing in improvements. And the easiest approach here is to take a specific type of harm and go through the analysis of what investment would it take to make a significant difference in reducing the number of adverse events or the severity of adverse events. Then carry it on to, if we were able to get to zero harm, what would be the investment return? But start with something fairly simple. And you'll find that the ROI on investing in specific challenges that we have in terms of adverse events can be significant. And that needs to be known not only by the board, but organization-wide. Last, we need to tie safety and quality actions to organizational-wide performance. Going back to an earlier comment, we know that the investment in safety and quality improvement, those actions also move performance up in all areas of the organization, including financials. So the real key here is then raising the urgency organization-wide. And I'm going to go to a example at Virginia Mason after Mary's passing. Within 30 days after Mary's death, we, as a board, senior leadership team, in front of the largest auditorium that we had in the organization and videoed, all board members, all senior leadership. In the front row were members of Mary's family. And we spoke as a board. I had the opportunity as board chair at the time to speak towards the importance of getting to zero harm and the critical need to be able to see harm through our occurrence reporting system so that we could fix it. We had introduced a patient safety alert system, occurrence reporting, if you will, about 6 months before Mary's passing. We were receiving about 150 patient safety alerts a month, which we knew was tip of the iceberg. When we spoke to the importance of reporting and made the commitment that all were expected to report, all will be protected when they report, and all will be held accountable, and spoke to some details about the occurrence report in front of the audience, Mary's family in the front row. The patient safety alert numbers 3 months later were at 500 a month. So we were lowering the water, we were seeing more of the iceberg, and it was a significant turning event for the organization. I don't think the board recognized how powerful it was to see the board taking accountability for quality and safety, senior leadership being in the room alongside the board and being a partner to the board, and having the patient in the room. We were told by our quality staff shortly after the town hall and subsequent town halls in our clinics that it was a watershed turning moment in the organization. So the point is here, we need to raise the awareness. We need to show the organization as a whole that we're committed to reducing harm and that focused upon adverse events is a way that we're going to do that. It's very powerful, it's very effective, and it gets the message across. So raising awareness is critically important. The second piece of the process is enhancing the focus on adverse events. And this part of the discussion is going to be a bit like a checklist, and certainly debatable in certain areas, and that's fine. But I want to challenge the group that to properly enhance the focus on adverse events, we really have to raise the bar. So serious harm notices need to be at the board and leadership within 4 hours. Initial findings within the next day. Findings updated at each board and committee meeting, and investigations completed within 45 days. Now, there can be certainly some extensions of that, but those extensions need to be Safety Quality Committee approved or board approved. We're also going to be talking here about the role of the board and the role of the Safety and Quality Committee, and those can be changed around a bit based upon the size of the organization. Don't be holding to specifics in terms of this is board and this is quality. The overall importance is that governance needs to be aware and governance needs to be engaged. So the investigating team composition needs to be based upon severity. And the significance of the event could include CEO, CMO, CNO. It should always include quality general counsel, risk, and really important, those closest to the work. Quite often, patient representation can add significant value, as can a board member participating in all or part of the investigating team's work. The team's role overall is to follow the investigation protocols that are set up for adverse events. The issues of transparency, disclosure, just culture, compliance requirements, corrective actions, the improvement work, insurance, making sure that the learnings from the adverse event are deployed organization-wide. That's the team's overall role and responsibility, which should be part of a policy, should be approved by the board, and the board should understand clearly the components of that process. The Safety and Quality Committee role. A patient should share a story of their care within the organization at each meeting. Not necessarily that one concerned with this adverse event, but a story to build the connection between real life patient and data and information. Adverse events should be first on the agenda. They should be allocated the majority of time. At Virginia Mason, we dedicated, after Mary's passing, we dedicated 90% of our time for a year to adverse events, 90%. And we met once a month for 2 hours. During the first year, as I recall, we added probably 2 additional meetings, maybe 3, in terms of ensuring we didn't get behind in terms of the overall process. We met with the adverse event team rather than a spokesman for the team, so that it became very well known throughout the organization that the overall review of serious adverse events involved the board, and the board actually meeting with the team who was working the corrective actions and the investigation. Very, very powerful in terms of it being a direct approach, effective, efficient, and everybody knew at that point in time that truly the board was focused, governance was focused on adverse events. We always ask for the review to be humanized. Patient family, overall effect of harm. The team reviewed their investigation, recommended corrective actions. We probably returned 15 to 20% of the recommendations for additional work before the committee approved them by asking why over and over and over again. One of the things that became very important in the process was to keep a log of those events that were still open so nothing fell through the cracks, so that we could add resources if necessary to ensure that nothing was left open beyond the time frame that we had agreed upon. Really key, really critical. That needs to happen at the safety and quality level, and the board needs to see that as well. At the board level, patient or staff shared story to begin each meeting. This needs to be done very carefully. If you're just starting, there are a number of protocols that are very helpful to ensure that everybody buys into the process. It can be nervous for the CEO, some in the organization. It can be confused with moving over the line in terms of governance and management. Every organization that I've worked with who has gone down this path and done it correctly, board members ask for more patient and staff shared stories in the organization than they typically had originally started with, getting to one for each meeting. Very important, very critical. So at the board, adverse events should be first on the safety and quality agenda. The committee chair should lead the discussion. It should again be personable. The board should not just rubber stamp the safety and quality committee, ask the right questions, ask for an extended review. And a best practice would be for the safety and quality committee as a whole to meet with the board once a year, and for an event team to also meet with the board once a year, again, in terms of connecting the direct process that's being used with the people who are actually doing the work. Trustee roles. And this is really more than trustees. This is the stakeholder roles as well. But a trustee should individually round to the bedside and care areas quarterly, and should group round to the bedside care areas twice a year. They need to be separated. People are not going to be open to a group of 12 board members coming into their work area. They will be open, and you can impart a message and listen to what you want to hear and need to hear if a board member is doing it individually with not the CEO, but with the chief nurse for that particular floor, as an example. Again, needs to be done well, but those groups who have begun this, there are more requests to round than often the organization can handle, and that's a good thing. The trustees should share the rounding experience at each board meeting. And moving to other tasks, taking the role of a patient in discussions. And this applies to everybody when you're talking about safety and quality. Don't get hung up on the organization's view, but think about it from a patient perspective. Also think about how, if the community was involved in the discussion you're having regarding safety and quality, what would they think about the decision that you're about to make and the discussions you're having in terms of getting there? So the trustee then, coming back to the trustee individually, needs to ensure that they are participating to learn in the investigation process, perhaps in corrective actions, and certainly in performance improvement work, which can be a very rewarding educational environment. Patient participation, very critical. It connects the heart with the data. And we get so overwhelmed with data, we often don't have time to do that. But it comes back to sharing a story in the boardroom or in committees, participating in investigation work, corrective actions can be very, very helpful to have a patient in that process, and in improvement work. And what a number of organizations are doing that I think is very helpful is asking a patient to be engaged in training in areas, particularly with respect to the importance of disclosure, and to have a patient and staff member be involved in the training in terms of just culture and just culture process. So overall, some supportive practices that need to be considered in terms of the focus on adverse events. You need to have an organization-wide decision-making policy that prioritizes the investment, both financially and in human resources, to safety and quality improvement. So when the board, committees, others in the organization are looking at what are always limited resources, safety and quality should be a high priority. And there should be a policy associated with that that everybody understands. Whistleblower input should be reviewed quarterly by either the board or the Safety and Quality Committee to ensure that all of the input, feedback that's being received is being appropriately handled and being educated in terms of what that what those inputs look like. Credentialing report. Seen too many cases where credentialing report is rubber stamped by the time it gets to the board. Should not be. Credentialing should have the time allocated in order that the right questions can be asked of the credentialing process, and particularly where there are exceptions being made is where the board should really focus. Did we handle that properly? The board should ensure that they see, they review, they discuss each and every culture of safety survey finding. Should be discussed in depth. That leads the board to being able to support the issue of transparency, open reporting, critical issue. And those survey gaps should be part of a cultural enhancement plan, which you see very seldom within an organization. You also very seldom see a board committee that is focused upon culture and culture enhancement. When we know that culture trumps strategy, no pun intended, when that happens, the importance of culture should rise to the level of significant board focus, and in many cases that should be a board committee or a board task force. Presentation guidelines. This may seem like a detail, but how often in a board or a committee have we seen presentations that are not associated with the work plan, are kind of out of nowhere? The other issue with respect to guidelines is giving those presenters clear direction in terms of what really works. So making sure that presentations have an objective, have a request in terms of what they're asking for the board, and that the board committee would like 60% of the time, 60 to 70% of the time allocated to discussion, not to reviewing PowerPoints that have already been provided in the earlier materials. The presentation guidelines are really key to being more effective and having more time to focus upon the adverse events. Next three items: 10-minute safety and quality education at the end of each meeting, snapshot evaluations, and board, committee, trustee self-evaluations and 360 evaluations with feedback from peers annually. We hold management accountable, we hold staff accountable, we have to hold ourselves accountable in the same vein with the same process and same procedures. So what we haven't talked about, which is elephant in the room, if you will, is the need to see harm before we can eliminate it. This goes to what we found in after Mary McClinton's death, and how quickly we could affect openness and transparency by ensuring that the organization knew that the board, senior leadership, was in tune with the importance of openness and transparency, protecting those who raised their hands, and fairly and equitably holding those accountable for raising their hands or avoiding that process. So how do you see whether you're seeing all the harm or not? Certainly a key piece is the annual Culture of Safety Survey, discussion of the action plan to fill those gaps, and providing the resources to do so. Those gaps are not free. They require a focused investment in terms of closing the gaps. And we're not fair to the organization unless we provide those funds and do it in a timely manner. When trustees are out rounding, They should be asking questions in terms of openness and transparency. And those that they are meeting with and discussing issues with should be sharing their issues with respect to openness and transparency. The board needs to know, board needs to see before they can help and support openness and transparency. And lastly, and I put this responsibility on each of us as trustees. We need to ask the questions that ensure that all reported adverse events are appropriately disclosed and that the investigation recommendations are fulfilled. That ultimately is an individual trustee responsibility, and we need to make sure that we do that on a routine basis to ensure that nothing gets left behind with respect to the abilities to reduce harm. So a few brief remarks about committing to zero harm. And this is beyond the scope a bit of what we've talked about here in terms of adverse events, but I think it's very, very important. And I'm just going to phrase this and discuss this briefly from the aspects of if you waved a magic wand and were able to select 9 leading practices to get to zero harm. Could be 8, could be 10, I picked 9. It's a nice odd number. What would those practices be that you would invest in that would make the greatest impact in the shortest period of time? Much like the case for adverse events, you'd establish the case for getting to zero harm. Financial, personable, obligation, patient-focused, staff-focused. You'd make the role of governance and management for safety and quality clear. And that isn't always clear in all organizations, and it's a barrier to improvement. We should have compacts in place between the board and trustees, the board and the CEO and senior leadership, compacts that deal directly with safety and quality, and the role of the group on the left-hand side of the compact and the group on the right-hand side of the compact. It's the only way we're going to clarify governance and management roles. We need to establish a safety and quality decision policy, like I chatted with before, that prioritizes the resources for getting to zero. If we don't do that, it's another flavor of the month. We need to raise expectations by establishing the targets, the goals, the timelines to get to zero. Having zero as one overall arching goal has worked for many organizations. You obviously have to have the underlying pieces of that in place too, but we have to set the benchmark. It can be years out. It doesn't need to be months out. It can be years out. That's okay. But it needs to be an ultimate goal of the organization. Number 5, don't rubber stamp anything. Ensure the effectiveness of the safety and quality plan by looking at performance, by looking at best practices. Same for credentialing, risk management. We have to ensure the effectiveness of plans before we approve them. Culture. Establish a board level culture committee or start with a task force with stakeholder representation, patients, staff, so that we get to the areas of where we can make strategies work. That is an environment where employees can do their best. And item number 7, it's important to understand that culture change does not need to be this 5-year federal project that involves significant investment and resources. You can take your existing values, which in many cases may be very appropriate, and you will make a significant impact in a short period of time by developing and establishing the actions, specific actions, that an individual can take to demonstrate the commitment to that value. And on the other side of the sheet, list those actions that if one would take would undermine the commitment of a particular value, be it trust, respect, compassion. It doesn't have to start at the organizational level. It can start with a department. Do some work to develop those actions, and then spread and deploy in draft form for thought for other organizations. You can make an impact in months versus years by simply making your values important. Number 8, ensure all voices are heard in the boardroom. Patient and staff need to share their stories. Trustees need to round and share their experiences. And those closest to the work need to lead the topics that are being discussed, not the director of the area that the topic is coming from. Those closest to the work need to be involved in the discussion. Last, certainly not least, insist on fair and equitable accountability from the boardroom in terms of holding everyone responsible to the bedside. And we cannot allow inappropriate behaviors to continue to exist in the organization if we are committed to safety and quality improvement and if we're committed to engaging in adverse events. It cannot happen. We have to be able to address those issues quickly, immediately, but fairly and equitably. So with that, I truly hope that this has been helpful. I realize not all of you are board members or in a place to affect what the board can do. But there are many, many ways that hopefully I've been able to open some thoughts on in terms of how you can get the board engaged and how you can help make a difference in adverse event awareness and ultimately reducing preventable harm. Thank you. Thank you for participating. Be happy to answer any questions you may have. And back to you, Chuck.
Well, thank you. Thank you so much. It is great having you speak to our audience. Absolutely terrific. It has been really, really fantastic to have you review so many things that I want to kind of come back to regarding the specific duties that the board has, and also these great action items and action areas where the board can work. John Nance could not be with us live today, but I asked John a couple of questions and asked him to respond. And I know you've worked with him for a long time and that you have had a lot of great conversations, and that he is just one with you in terms of his belief in what you're doing is just right on. So John, for those that don't know John well, John is the current ABC safety commentator for ABC News. He is a former captain with Alaskan Airlines. He was one of the founders, actually, of one of our major patient safety organizations. He's been on the board of directors of them, and also has worked and advised many of the boards. He is a lawyer with a law degree from SMU, and he is a both fiction and nonfiction bestseller. And you see on the slide before you, Charting the Course and Why Hospitals Should Fly are two great reads for those that are new to patient safety. Absolutely terrific, terrific national treasure in patient safety for us. And I asked John, my first question to John was, please give us your take on your experience and why it's so critical to work with your board or work with boards after a serious adverse event. Kyle, would you rather take? John, please give us your take based on your experience of why it is so critical to work with your board after a serious adverse event.
One of the most misunderstood challenges, I think, both when a bad event occurs in a hospital as well as when there's a rumor of one, but nobody knows the actual situation, is to keep the board not just informed, but intimately involved and engaged in every aspect of how senior administration is understanding the situation and formulating a response and what has been done so far. And the reason for this is not just oversight, it's also a matter of bringing the board into the real world of how these things have to be handled both now and in the future. Boards tend to be very disconnected, as we all know. The reason, among others, that this is so important is not just as a matter of keeping the board engaged, but it's also a matter of bringing the board in on an intimate basis to the decision-making and thought processes philosophically. The senior administration does not operate in a vacuum, but to a certain extent, with the relationship with most boards, it might as well be a vacuum because the boards are not necessarily involved in the day-to-day thinking. But an adverse event, especially the death of a patient, is something that needs to be felt as much by the board and by every member of the board as just experienced on a factual basis. The philosophy with which senior administration approaches such a thing as an unforeseen and avoidable loss or possibly avoidable loss of a patient or a major impact of one sort or another is incredibly important because it's not necessarily what's stated. The philosophy as actually practiced by the folks in administration may be much better than what's on paper, and in some cases it could be worse. It could be talking a good game and not following through. And in many cases, the best of administrations, the best CEOs and COOs would not necessarily know that they've drifted off without the oversight capability of a board member or a board leader or the board itself and saying, you know what, I think we need to revise the way we do these things in the future, or I think we need to do this or that, or to institutionalize the way you did handle it. The main thing is, it's not so much a hospital needs to speak with the same voice. Certainly the attorneys, as I am, will tell you that, but by the same token, you are in charge, the board is in charge, and ultimately the buck stops there. And to have any question at all about what the philosophical approach of the board is to what the hospital should be doing, how they should be contacting the patient's family, how they should be dealing with the public if this is something that's blowing into the media, and how they should be dealing with risk management, not on a strategic basis so much as on a heartfelt basis of what's the best thing to do. All these are very, very important points. And if you just sit back and use oversight later on, that's fine, but you really do need a direct and immediate involvement.
As an attorney, you often tell us about the legal responsibilities of a hospital board. Can you briefly explain them to us?
As an attorney, I can tell you that one of the things I have tried to pound on over the years is not only the 1965 Darling decision in Southern Illinois, which basically went to the Illinois Supreme Court and said that the buck stops not at the CEO's desk, but at the board for every medical decision made in a hospital, but to explain why that's so important. The fact is, and I won't go into the facts of that case, it's well known, but the fact is that too often the tendency has been, and it has been well developed over time, for the non-medical people who don't have any training as doctors or nurses to want to simply say, well, this is a problem for our medical exec. Anything that has to do with medical practice, medical decisions, bad or good, strategy, or any other aspect of practice, that's something we need to turn over to at least the CMO and probably the med exec, because the board simply can't handle that. Well, it's fine to go for advice. It's fine to push it off to the extent of saying, can you research this? But the Darling decision was important because it said, as a matter of law, which was, by the way, refused certiorari at the U.S. Supreme Court, so essentially it becomes the law of the land. The basic statement was these things are too important, whereas they affect the care of a patient, which should be the highest level that medical science can provide. They're too important to just be that of an individual doctor or an individual CMO, no matter how good, or an individual and dedicated board of doctors. This has to be something that the hospital, down to the sinew of its existence, down to its corporate DNA, is in lockstep with understanding. A decision made about medical practice, positive or negative, is the responsibility of the board, and it's not something that the board should take lightly, and it's not something that can be sloughed off. In this particular case, what the Supreme Court of Illinois was trying to say was precisely the level of importance was too great for a company or that was running a hospital for a corporation and now for an LLC or any other form to say, well, that is a medical decision and we cannot be held responsible for the medical decision. Yes, you can. You will be. And ethically as well as legally, this is something that they can't be shirked. Now, how do you make sure that the board understands this, and how do you make sure that the board carries it out? It has to do with training over time. It has to do with very forthright, extenuous statements by the chairman of the board, by the other board members, and certainly by senior administration, that we're not just going to give you a fait accompli of something that's happened. We're going to give you the entire chapter and verse at a point in time when there are decisions to be made on how to react, how to handle it, how to change things in the future. And yes, we're going to get into the sinew of medical practice and decision making, and some of it is going to be difficult to follow if you've never had any medical training. By the same token, the buck stops at the board, and that is incredibly important. There is at least one U.S. senator who wants to make board members of hospitals individually liable along the lines of Sarbanes-Oxley and its application to for-profit corporations. Senator Charles Grassley we're talking about. I personally thought that was a misguided idea a number of years ago, but the further I've gone down the road of his thinking, the more I have to agree that that is probably going to be the progenitor of putting us into a more professional board realm in which we end up paying our board members. We require a tremendous amount of additional education, including some degree of medical, and we end up with a higher level of responsibility for every decision. Again, not just in accordance with the Darling decision, but in accordance with the philosophy that these decisions that affect life and death of the community who depends on the medical precision of a hospital or a clinic in their midst, it really has to be reflected not just by the senior executive staff, but by everyone in governance, and that, of course, is the board.
So, John, as always, is very eloquent. Tom, do you want to kind of react and unpack a little bit of what John said? These were terrific comments. Maybe in the context of our audience, which is 70 to 80% clinical leaders, quality leaders, if a lot of the things that you've recommended and their boards may not recognize this additional responsibility that the board may really have, what's your message, Tom, to kind of react to what John has said, and your message to those that maybe have not to date been as engaged with their boards? Maybe a good hospital, but just not really as actively engaged in the best practices that you have described and are aware of the duties that John has described.
Well, I think the first thing to recognize is that these are not, what we're talking about are not additional responsibilities. They truly are core to the duties of care and business judgment that board members have. The attention to adverse events, from my perspective, is really the tip of the spear. It's something that there's a passion associated with it because of the harm has taken place, and therefore it's something you can get your arms around. It's an ability to affect and engage in adverse event very easily and very quickly. And I don't look at it as additional responsibility. I look at it as a focus point that a board has responsibility in terms of responsibility that can be used to move safety and quality forward within the organization.
Gotcha. I think that react to this issue of whether you think that boards will have an increasing personal liability for the actions of the organization, especially as we look at these cases we're following. It's going to be pretty hard for the board to avoid some responsibility for the cases that we started with.
I agree, and not only the board, but the individual trustees on the board. If you look back to Sarbanes-Oxley, for example, it was some very egregious events that triggered the Sarbanes-Oxley policies, and frankly, rightly so. And if from a board perspective, we're not following the policies that we have set up to be followed, and we don't do, quote, what's right, unquote, then someone else is going to obligate us to do that, and it's not going to be something that we're going to like. So, we've got to do the right thing. We've got to follow our processes and procedures. We have to be held accountable to doing so. Or someone else is going to involve themselves, and the pendulum's going to swing way over to the other side, and it's not going to be a happy day.
Absolutely. I think that our frontline workers feel so removed from the board that oftentimes they don't think of reaching out to the board if they've had no recourse in an environment where something has maybe gone wrong. Arlene, do you want to kind of comment on how important you believe, maybe add a little bit more about why you believe and why our dear friend Dan Ford, who is the tireless champion for getting patients and families involved in root cause analysis, why we need to get patients and families more engaged and involved with the boards, especially in light of your experience in workplace violence and bullying?
Yes, I think it's very important because through my experiences, I think it's in everyone's heart to do the right thing. But sometimes it's not always easy. And I know when my daughter was growing up, that was the lesson I taught her. You do the right thing. And sometimes it will be hurtful to you, but it's the right thing to do. So always it starts with leadership and their commitment to the patients that they serve. But when something goes wrong, it's so important for the patients and the family members to know what happened. And you can only get that if there's an open board, open hospital, open leadership to that. And when patients and families are invited in to the process of prevention and improvement, it does become a vehicle for healing for them. It's telling the board and the hospital are telling them that their loved one's injury and death, it mattered. It mattered to them. And they're going to take steps to change that. So I think it's very important and as a frontline worker, I worked 11 years in a long-term care facility. It's very important to listen to them. I was non-clinical, but I see things that are right and wrong, and you have to have an open culture where it would be comfortable for me to go to my superior and say, this is what I saw. Not in a form of criticism, but in a form of improvement. And a frontline worker has to know that they're not going to be retaliated against. So I just love the presentation. I think Tom is a great advocate for patients too, with his comments of inviting them. So thank you.
Great. And so, Tom, coming back to you, and I want to advance to our survey right now. This topic is just so important, Tom, and we really appreciate your comments there. I'm going to go through the survey questions and then come back to you, Tom. And anyone that would like to ask questions of Tom, go ahead and fill the survey out. And then please put your questions in the question window. We will finish in 7 minutes. The first question is, I'm interested in another webinar presenting governance board issues, and the specific governance board issues I would like to have covered, you can put into the free text entry questions. So if you would like more, let us know. The second question is, I'm interested in a webinar presenting infection control issues. It's been some time, other than sepsis, which is a super hot topic, Tom, and that we are getting just continuous requests for sepsis, and I think we covered it 3 times last year. And but in addition to sepsis, or along with sepsis, infection control issues, and what infection control topics in the free text entry, if you could let us know those questions. The next one is, I'm interested in a webinar on pain management and the latest on the opioid issues. We know this is just an absolute crisis that's going on in our country, and the proper and adequate pain management at the same time that we're trying to manage drug diversion and other issues we really need to address. So specific pain management and opioid topics that could be covered. Then we're asking again on the mortality. We know in May, in 2 webinars from now, we will be covering mortality reviews. Is there anything that if you would like to attend that, let us know. But also the topics of mortality reviews, we're seeing a real uptick in the number of organizations run by Dr. Jean Huddleston, a number of cancer centers and other major centers that are joining that. Now, when I come back to you, Tom, and then we'll close with Arlene at the very end. Tom, as you think about organizations that may not have been as engaged, and maybe they're smaller hospitals, and they really haven't had their boards really actively engaged, when someone brings in someone like you as a best practices advisor, how long does it take to really take a typical 200 to 300 bed hospital that's in the community to really get going on these best practices? You know, how much time does it take someone to help them, and how much time does it take for them to really be able to adopt and really get kind of a robust board engagement in quality and safety?
Good question. So what my approach is to go in with a assessment tool that lays out all of the governance best practices and asks various folks in the organization whether they believe that best practice can make a difference in their organization or not. Maybe they're already doing it, maybe it isn't effective in their organization, but taking that survey and combining it with interviews with various folks within the organization, not just the board, but the board committees and some of certainly the senior leadership and CEO groups. That survey and that interview process can be a 2.5-day process. Taking the survey data, getting back with the organization and with the interviews, we can lay out graphically for the organization where they can make the biggest difference in safety and quality based upon those in their organization who have rated the best practices that we've laid out for them. That then is made available to the organization. Perhaps they can move forward on all those best practices then with no further assistance. Other organizations may want assistance in terms of best practice formulas, best practice templates, and so forth. This is not a multi-month issue. You can understand what best practices can add the greatest value in your organization within a 3 to 4 day process.
Right. And so Lisa Caprell has asked the question, do you have frontline staff involved in an event attend the RCA, or staff members similar to those involved in the event, and why?
Yes, and because they add value to the overall process by always reach out to those closest to the work, because they're the ones who really know what the work is all about and the challenges and the opportunities and the barriers for improvement.
My question for you, Tom, is the very first time that I was exposed to the trustees going on a rounds. It was in the middle of the night at the Cleveland Clinic, which was really, really impressive to go and follow along when they would go to different facilities in the Cleveland Clinic in the middle of the night to talk to the staff that are there really holding things together at night. And it was so instructive to understand the challenges and the resources that were required to keep an operation going. if an organization wanted to start some of these events where you get the board actually communicating with the front line and coming in and sitting down and saying, hey, what was your last near miss, and what's keeping you up at night regarding safety and quality, and getting those kinds of programs together as a frontline individual. How do you get some of those programs going when you're the safety and quality person, and there's a lot of power dynamics that are going on, and when you've never done something like that, it's a little hard to get started.
Yeah, so you start with a template. And that template is a practice that has been developed over time that works in other organizations that you can consider for working in your organization, and you modify it for your specific needs. You move it in the organization up to a board committee or an individual trustee or to the board, and you can say, I think this would really work in our organization. And you reach out to someone who can speak to the capability of that practice to really make a difference in the organization, so that you have the courage that it's been done before, and you have the inspiration that it really will work.
Great. Well, listen, Tom, we could go on forever. These are just such a important topic in getting boards involved, and we'd love to explore with you at another time the importance of having people with clinical training on boards, because we know there are a lot of people could really add great value to organizations with their clinical backgrounds. However, our time is up. So I want to thank you, Tom, for just doing a terrific job and really getting us to sink our teeth into the topic. Arlene, would you please close us with the voice of the patient? And God bless all of you, and we'll see you next month. Arlene?
Okay. Well, thank you, Tom, so much for your presentation and for advocating for patients. And thank you, everyone, for being here on the webinar. And I just want to remind you that you could share this webinar with others on the website. If they couldn't be here today, you could listen to it. So have a good rest of the week, and God bless. Thank you.
Great. Thank you all. And we'll have our speakers stay on just for a quick performance improvement loop to see what we can do better. And we wish you all a great month.